What about the guidelines? KDIGO is an association to come up with some guidelines to direct us to wherever we are in the world to deal with our patients with kidney diseases, people with kidney diseases. This is not directed only towards the physicians, but also anyone giving kidney health care to people in need of it. And the previous guideline was in 2012, and it took us like more than a decade to come up with a newer one, because since very lately we didn't have any randomized controlled trials regarding the use of any drugs or any interventions to prevent against the chronic kidney diseases. As a team, we had a diverse group of people coming in from different parts of the world, representing patient population, scientists, researchers, statisticians, internists, nephrologists, pediatricians, and everyone to come up with such a guideline so that we could help you how to treat your patients or guide your patients with chronic kidney disease. The previous guideline had 5 chapters. The new guideline also have 5 chapters. What we have tried to summarize the topics, which was a little bit complicated in the previous guideline. And we still have the evaluation of chronic kidney disease in the guideline, then risk assessment for people who are likely to develop chronic kidney disease, which I'm going to talk about, who those people are about, and delaying the progression. And if we cannot delay it, how to deal with the morbidities, and especially the topic is about medication management in those people and optimal models of care, because this is a continuum of disease actually. And as guideline providers, guideline writers, our objective is to come up with some ideas, some rules, some regulations, or some advices to people around the world so that they can lead their treatment regarding these patient groups. And this also brings an idea about the area for future research, because we look into the data that is available and figure out that we don't have that much data actually in real life. We hear about things going about our patient population, but we need hard evidence to come up with real recommendations, and it's rare. And we have to be also very mindful about the impact on the regulations and the policies and the culture of the regions, because we have around the world some very restricted areas where you cannot provide this care even if you wish, and even if it's stated in the guidelines. So we have to take into account our own culture, our own resources, restrictions, regulations, and also the expectation of the people as well. So with the definition and the classification, there's no change, thankfully, in the definition and classification of chronic kidney disease. Chronic kidney disease is defined as having a structural or functional changes in the kidney structure or function for lasting at least 3 months. If it's less than 3 months, we think that it could be acute kidney injury. So we have to have some idea about it's going on for more than 3 months. And it has an implication for kidney health. And it's not only about having a glomerular filtration rate, which is told about as GFR less than 60 mLs per minute. That's where the cutoff line where you will have a serum creatinine higher than the normal level. So our serum creatinine level, our old friend, is not as precious as other biomarkers. It's a, what would I say, tough marker, not precise enough to detect earlier functional loss in the kidney functions actually. So to come up with an idea that it has been going for more than 3 months, you have to look into the files of your patients, if it's available. Now in our system in Turkey, we have the e-numbers that makes us reach out backwards 10 years. So I look into my patients presenting to my patient for the first time. I look into their lab results. They are referred to me because someone tells them that they have a chronic kidney disease. They think that they end up in dialysis. They come into my outpatient clinic bewildered with fear and anxiety that they're going to become dialysis patient, but it's there in the labs. When you go back, their creatinine is high for the last 5 years, 7 years, so you might have some other resources to look into, hear about the history of that person. You hear about the family history, you hear about their previous results, previous operations, any imaging that will help you to determine if this has a chronicity for you to call that person with chronic kidney disease. And if you don't have that measures, what you do is you see that person with an increased creatinine. Please don't advise them to drink a lot of water and forget about this lab result. You have to do a repeat test to make sure that this goes away, or if it's staying, then you take care of that person as a chronic kidney disease. But for pediatric patient population, for children, it's totally different. If you have a newborn with kidney disease, they are definitely called chronic kidney disease. You don't need to do any repeat tests, and you treat them accordingly with their guidelines with the pediatric. So with the new guideline, we came up with this continuum spectrum. We start from childhood, then into adolescence, then for females, pregnancy and lactation, and you get older, you run into other problems, and as you get older, elderly, then we have problems with the frailty, and we have to be careful about how we treat these patients and take care of these people actually. So what are the practical points for you to act accordingly in your clinics, in your outpatient clinics, in general care practitioner offices? Well, we have some tools to detect if that person has a kidney disease. One is the urinary analysis, which can be done probably everywhere easily. Looking into the urinary albumin-creatinine ratio with spot urine analysis, that's going to be a fresh morning sample if available. And then look into the serum creatinine, which is also a lab that is done probably everywhere around the world, and it's not that expensive, it's cheap, but we have to repeat it to make sure that this is not a lab that is related to urinary tract infection. If you're looking into urinary albumin-creatinine ratio, which might be affected by a urinary tract infection, so you have to exclude that. You have to repeat the serum creatinine, that this is not a lab taken like you ate a big meal, like I was served yesterday with lots of meat, and then you took a creatinine level. Your creatinine level is going to be high up, and you don't assume that this is chronic, and think about acute kidney injury as well till you come up with the definitive diagnosis of chronic kidney disease. And if you have someone with chronic kidney disease, as in any disease, we have to look into the real cause of this disease. We have to take all the family histories, hear about their symptoms, signs, family history, look into the imaging techniques, be it ultrasound or more defined imaging techniques with the MRI or scintigraphies or Doppler ultrasound, and look into the genetics. For some of the diseases, chronic kidney diseases, nowadays we have the genetical examination labs also available, and look into the social and environmental situations, because we have some chronic kidney diseases related to the environment and actually the climate change, which is called CKD unknown, CKDU, which is seen in Latin America and South Asia as well. So we have to look into the causes. And we still advise you to a kidney biopsy if it's available to do that, if it's advisable to do that, if the kidneys are not too small. But yesterday I learned in the hospital from your interventional radiologist that they can do biopsies safely in small kidneys as well, which is good, because sometimes we get very reluctant as nephrologists to stick in a needle in a small kidney, but still kidney biopsy is the option to further come up with a diagnosis for people with kidney diseases as well. And when you think about a biopsy or sticking a needle into a person, you are afraid of the complications like hematomas. They're not that rare, but they're not mortal. So please do not be afraid of doing biopsies wherever it is available. The other parameter that we use to diagnose our patients with chronic kidney disease is coming out with glomerular filtration rate. I'm old school. I'm used to asking my patients to collect 24-hour urine and then the measured GFR, which takes a lot of effort to do that, especially in the female patients. But now we have the estimated GFR using different formulas to come up with a GFR result. So you could choose any of the formulations. The latest one that we advise people to use around is the CKD EPI formula. And it's on the app. You don't need to memorize it. Just look into your smartphones, and you will come up with the formula, and you stick in some numbers and the gender, and you come up with an estimated GFR. But please be aware that this is an estimated GFR and depends on your serum measurement of creatinine, which might be affected with other diseases, drugs, which are increasing the reabsorption of secretion of creatinine, and you might not be having the real ones around there. So we recommend to use the serum concentration of the filtration markers using valid equations, and we want the clinicians, the labs technicians to report the eGFRs according to the rules and to report them to the nearest number available. And we recommend the lab technicians or the lab physicians to report any eGFR less than 60 ml per minute in bold, in red, in stars, whatever it is called in your lab results, because that's the number that many of our physicians, other than the nephrologists, or the patients do take into account. That means that you have a decreased kidney function. That means that you have to decrease the amount of drugs that you're going to use. That means that you don't need to use NSAID for your patient population, or the surgeries that you're going to do, you will have to give anesthetic material in a different way. So those are the numbers. And believe me, many of the patients referred to me for the first time present to me because they have an eGFR less than the within the range. And actually, when you do a measured GFR, they have a better one. But it's good to remind them that they might have a problem with the kidneys. So that you have to be careful how you measure, of course, your creatinine. And the way to determine your serum creatinine level is to use enzymatic assays. I'm sure that you're using the newer technologies and assays here in your labs as well, but it's not the same everywhere in the world, so we had to comment about these technologies to measure the serum creatinine level as well. If you have issues with serum creatinine and eGFRs using serum creatinine level only, the formula, then you can integrate cystatin C into your formula as well. Then we have the eGFR cystatin creatinine formula, and cystatin C is another marker that we have been using for the last decade, but it has its own problems as well, because cystatin C is produced in every cell in the body, and if you have a liver disease, chronic liver disease, or thyroid disease, your cystatin C goes up. So you might also have some problems, but to have a better idea of an GFR, glomerular filtration rate, if you can have both creatinine and cystatin C, you will have a more reliable result compared to measured GFR. If not, if it's not going to work, then you're likely to do the measured GFR, ask your patients to collect 24-hour urine, or if it's not available, you could ask for a measured GFR for the timely collection of the urine so that you have an idea how much your kidneys are working or the patient's kidneys are working. What about the pediatric population? Well, they all have their own formulas as well, and for that formula you need to put in the height of that child. And there is also another point that needs to be stressed or mentioned about, is that you will not call an GFR less than 60 mL per minute as decreased kidney function unless that child is over the age of 2. So they have their own limitations if you're taking care of a child. Just to keep in mind that they differ. What about point-of-care devices? We're in such an environment that we have all the available tools in our laboratories, so we can do all kinds of serum analysis. But if you're living in sub-Saharan area or in some parts in Latin America, you might not have the resources to measure your serum creatinine. So, or in disaster situations, the point-of-care testing is the a tool that you can use to measure your serum creatinine, and it has advantages. You take a very small sample, it's like measuring your blood glucose levels, and you come up with immediate result about the serum creatinine. This is also an estimate, but gives you a clear idea how to move forward with that person, especially in disaster scenarios. If you're dealing with your dialysis patients who were not into dialysis because of disruption of the dialysis services, and you need to know about your serum creatinine or even potassium, there are point-of-care testing for potassium as well, for sodium and your bicarbonate and your pH and even RNA, and you could use these testing methods to come up with greater ideas. So that's about how to diagnose your patients, but it's not, the continuum of the disease does not stop there. Our people or patients with chronic kidney disease have an increased risk of ending as end-stage kidney disease patients. That's the people requiring dialysis or kidney replacement therapies. That's also including the transplantation. So if when someone comes to you and you determine that they have kidney disease, they will ask you, when will I end up as a dialysis patient? And some of my colleagues like to give them some lifespan without dialysis. And you could use all these risk equations to come up with an idea and to give feedback to your patients about when they might require dialysis. If they're younger and thinking about the lifespan of an average person nowadays, like 60, 70, they might end up as a dialysis patients if they are lucky. Because people with chronic kidney disease also have increased risk for cardiovascular mortality and mortality. And we lose some of our patients due to those comorbidities on the way to the dialysis. So we say, if you're lucky enough, you might need dialysis while you're living. But if you're meeting with someone at the age of 70, it's likely that they will not need dialysis throughout their remaining life, but still you have these equations and they're available online as well to give them an idea when they might need dialysis throughout their lifespan. And you give these hot tables or figures, and this comes from the CKD Prognosis Consortium, which was published a couple of years ago. And depending on your eGFR, your height, weight, gender, age, you might come up with ideas how you will move forward with your disease. And of course, we have to keep in mind that each year we come up with newer drugs, newer therapeutics, and newer guidelines in terms of how we're treating our patients. So that might change, but this gives you an overall idea of how they're going to move forward. And these are the other equations that have been used throughout the other studies that have been done in States, in Europe, and you can choose which one you would like to use in your offices to give them an idea how they're going to move. And this is our pyramid, actually. You might have seen it in the cardiovascular risk pyramids as well. Those are the ones at stage 1. We have 5 stages of chronic kidney disease, by the way, with starting from stage 1 to stage 5, where that person needs kidney replacement therapy. And there are the stages where you could intervene as general practitioners, as internists, then nephrologists, and then multidisciplinary team taking care of those patients. And if they need kidney replacement therapy, then we need the help of our surgeons to do transplants or put in the catheters, vascular surgeons, put in our vascular accesses for hemodialysis as well. And there are risk calculation tools, prognostication tools, and if you have a 5-year kidney failure, like 3 to 5%, go ahead and follow them in the nephrology clinic. If they have a risk of 10% in the next 5 years' time, 2 years' time, then refer them to multidisciplinary team, including the dietitian, including the cardiologist, and asking about the other processes that might be needed for that person. If there's a risk of 40% of having kidney failure in the next 2 years' time, that means that you have to introduce them to the transplant team or the dialysis team so that they get educated, or actually hear about the kidney replacement therapy modalities and have a shared decision with their following team as well. But beware that the risk equations that you're going to use for people with stage 3 to 5 is not going to work for your stage 1 and 2 patients. That's a totally different story. Once you have a GFR less than 60 ml per minute, story changes. For those with stage 1 or stage 2 kidney disease, it's probably take a longer time for them to develop any kind of kidney failure, actually. So what about the cardiovascular risk prediction tools? You could use any tool that involves people with kidney diseases in their equations or in their formula or in their studies. Otherwise, you will lose some of the patients with higher cardiovascular risks and your treatment might be postponed. So we take into consideration the cardiovascular risk for our kidney patients as well. And you're going to see in one of my algorithms that we have to take care of the high cholesterol levels and we have to administer statins to some of our kidney patients. Interestingly enough, this hasn't been proven otherwise yet. For dialysis patients, using statin didn't improve their outcome as kidney patients. That was for a couple of years ago, actually, but we still need to do some more randomized trials about that as well. So for managing our chronic kidney disease patients, we have to look into the real cause of the kidney disease. If this is a polycystic kidney disease, now we have some drugs to treat that disease that has been approved, and we have been using them for the last 5-7 years. So we have to administer them. If they have glomerulonephritis, we have approved newer drugs for IgA nephropathy, C3 nephropathy, and the other nephropathies as well. So we have to treat those as well. With vasculitis, we have our own treatments to treat those patients to slow down the progression of the CKD. But other than that, the targeted therapies, we have to have a holistic approach. And we were just discussing with our dear dean about the holistic approach to patients with coronary artery disease, heart disease, and kidney disease. And the first step is about lifestyle changes. Probably it's the same step for every disease, including diabetes, hypertension, chronic kidney disease, hyperlipidemia, and we have to change our lifestyle. And thinking about the modern lifestyle where we are eating lots of processed food, where there's lots of phosphorus, salt, and increased glucose, or the other, so-called avoidable ingredients. So we have to eat healthy, we have to exercise, we have to stop smoking, we have to stop drinking lots of alcohol, and we have to control our weight. Those are the first step. First, we have to change our lifestyle. And thinking about kidney disease patients who are going to be chronic patients, and just remembering my outpatient clinic where patients are presenting to me like and last Tuesday, I was with a student, first-year medical student, and I was introducing my patients to her, and they were like 15 years of follow-up, 18 years, 10 years, 12 years. So it's not adapting your lifestyle for a week time or 2 weeks time. It's going to be lifelong. So it takes energy and devotion from the patient side and also from the physician side. And you need multidisciplinary team, dietitians, physiotherapists, or psychologists to make sure that they maintain this therapy. Then afterwards, with the targeted therapies for the specific kidney disease, we have other tools that we give to our patients with chronic kidney disease. They were previously on the renin-angiotensin-aldosterone system blockers. Now we have the CGL2 inhibitors. Those are the drugs which have been approved for diabetic kidney disease, but now has been approved for also other chronic kidney diseases outside diabetic kidney disease, and those are the second step tools that we have to add on. And if we cannot control it, of course, the statins are there, then we have to add on the other drugs to control the hypertension, hyperglycemia, and the other complications related to chronic disease, like controlling their anemia, bone disease, or hyperphosphatemia, and the other comorbidities related to chronic disease as well. Well, with renin-angiotensin system blockers, aldosterone system blockers, we had a main problem with hyperkalemia, hyperpotassiemia. We were afraid that they would run into problems and the GFR is going to decrease, but we advise with the latest guidelines that please continue your RAS blockers even if your GFR is less than 30 mL per minute. But beware of the hyperkalemia, and if you run into problems with hyperkalemia, adjust your dose with RAS inhibitors, adjust your diet, or start your patients on anti-potassium therapies like the exchange resins. And with the CGL2 inhibitors, I was telling you, the story started with diabetic kidney disease. It was approved for them with albuminuria. Then they were approved for people with heart failure and chronic kidney disease. Nowadays, they are reimbursed for any chronic kidney disease, and we try to give that drug to each of our patients with chronic kidney disease to control their albuminuria. And in nephrotic syndrome patients, sometimes we ask them to buy it because it's not reimbursed in my country. For chronic kidney disease patients only, it's reimbursed for diabetic kidney disease, so we ask them to buy it out of pocket. And in some countries, they still don't have the CGL2 inhibitors. What about the new non-steroidal mineralocorticoid receptor antagonists? We have only one, as far as I know, that's finerenone, and there are some studies done with it. And that's also been introduced into diabetic kidney guidelines. It's an add-on therapy to the standard therapies to control the diabetic kidney disease as well. To manage hyperkalemia, as I told you, it's not anymore accepted to stop all the drugs now. Just adjust the dose, make sure that you control the diet in terms of potassium, send that person to the dietitian or give them advice how to cook their meal without potassium. You know, get rid of the first boiling water of the vegetables and beware of some kind of vegetables and fruits. And then if it's not okay, then use the licensed exchange resins to control their potassium on top of the renin-angiotensin-aldosterone system inhibitors and the CGL2 inhibitors as well. The other drug that has been discussed about in the guideline is the GLP-1 receptor agonists. Those are also anodone therapy to control the hyperglycemia, and this has been proven effective for the heart failure patients as well. So we will be talking about these drugs more in the future as well. That's for that. The other story when we were talking about the guideline was about hyperuricemia. That's an interesting story. There's no concrete evidence that to control hyperuricemia in a chronic kidney disease patient is going to slow down the progression of the kidney disease per se. If that person has symptoms related to hyperuricemia, like a gout episode, then you're free to use the drugs, anti-uricemic drugs. But other than that, there's no evidence for you to use anti-uricemic drugs to slow down the progression of the chronic kidney disease. This has been questioned with among my colleagues, so still we need some concrete evidence to recommend the use of these agents. What about metabolic acidosis? This was also a controversial area when we were writing the guidelines. We decided that we would recommend use of bicarbonate if the serum bicarbonate level is less than 16 ml per liter. But for the pediatric population, we have to start bicarbonate earlier because they have issues with growth problems, and we need to optimize their growth when they're a child. So the story is different for the pediatric population. What about the medication? Why do we have a chapter dedicated to medication in the guideline? Because our patients are on polypharmacy. When someone with chronic kidney disease presents to your office, they just have 10 different drugs. They are taking like 16 tablets per day, and they just mix up. And each time they present to another physician, someone prescribes them another drug. And in fact, you might realize that they are using the same drug prescribed by different physicians in other names, and it's just being toxic for them. So we need to monitor their medication and be aware of their medication. The other problem is about our female patients and the pregnant patients. We have to remind them about the use of teratogenic drugs. We have to remind them how to use their drugs during pregnancy and lactation. That's a huge group of patient population as well. We need to consult them about contraceptives. And with medication use, we ask our colleagues in the healthcare providers to help us look into the medication list of our patient population, including the pharmacist. And it's advised to use some online programs or apps to look into the list of medications those patients are using. As I told you, they might be using the same drug over and over again, and there might be some contraindications in using those drugs at that CKD level. And more importantly, there should be sick days defined to the patients. When I first heard about the sick days, I said, what is this sick day? Well, it's really important because your patients might become ill, they might have flu, they might have diarrhea, and those are the times, or they might have problems with sweating, they went to such a hot place, they're losing water, they become dehydrated, then they have to stop their ACE inhibitors or ARBs or other drugs to make sure that they don't run into problems with hypotension or an increase in the creatinine. But the other thing to remember is those are called the sick days, where you will not be using your regular medications. You'll have to stop it. But the real issue is that they have to restart these regimes, this schedule afterwards when they get well. So we stop the drugs and we never start them back again. That's a critical reminder. And it's also critical when they're going under surgery. Think about metformin, ACE inhibitors. We advise them to stop it like 2 days before the surgery so that they don't run into problems with acute kidney injury on top of chronic disease, but they have to restart it when it's appropriate as soon as possible. The other topic covered in the guideline was about the contrast agents, and we have very recent guidelines from the radiology groups about the use of contrast agent. Contrast agents are worse if they're used intraarterially, and we can use the contrast as we would use in the general population. We shouldn't be reluctant to have contrast using in the imaging if it's a must for that person. But what we do is for MRI scanning, we use the newer agents. For CT scanning, we use reduced dose of the agents, and you could just look into the guidelines to make sure that you approach your patients appropriately. And in the models of care, taking care of our patients also makes us beware that the patient is in the center. And we have to share our decisions with the patient. And we're talking about shared decision making in nephrology as well. This topic was covered in oncology more, making shared decisions with the patients. Now it's within our population as well, with the shared decision. And the patient, the person with the kidney disease, is actually in the middle. So what they feel about their disease is critical. And we're talking about patient-reported outcome measures in many of the randomized controlled trials. And we're not looking into the creatinine, GFR slope, decrease in the GFR, increase in the creatinine levels, twice increase in the serum creatinine levels, and etc. We're looking into how they're feeling. Are they feeling tired? Do they have any itches? How is their appetite? Are they able to go to work? And then we are putting these as measures in our randomized controlled trials. And that's going to be a critical issue in the next randomized controlled trials to approve some of the drugs that are on the pipeline as well. So this needs a team-based integrated care. We need the dietitians, we need the social care workers, but we might not have it in every facility. So we have to learn a little bit about how to teach them about healthy eating, healthy exercising, getting help for their other problems, and sharing their feelings about their disease with us so that we know how to move forward with that. If that drug that you're prescribing to that person makes them vomiting or having some nausea, it's not going to work. They're not going to take it, and it's not at your target, and you think that you're helping that person, but you're making their life miserable. So we have to take that into account with the new approaches. And education, of course. We need health literacy in the population. We were just discussing about our role as academicians, physicians, medical students, our role and duty for the general population to educate them about health and getting them known about health literacy as well. So back to the pyramid, we're talking about optimal care of CKD patients regarding their severity. If they're at very early stages, primary care physicians can take care of them. But if they move forward in the stages of chronic kidney disease, now they need the help of the nephrologist and also the cardiologist and the chronologist. And if they are progressing, then we need the help of our transplant teams or the dialysis nurses, PD nurses, for them to educate and get them ready for the next step of their life, actually. Because this continues till they die. And of course, we mentioned about the telehealth or remote patient monitoring, which was introduced more rapidly throughout the COVID era when we couldn't reach out to our patients and they were not allowed to come into the hospital to do their regular follow-up. You could do that with the newer available resources. And I think with the AI and all the things, visual things, and all the web-based applications, it's easy to monitor our patients at their home settings or local areas. And thinking about broad countries where there are not enough nephrologists or internists, it's a good idea to make sure that you control these patients remotely. Especially for home dialysis patients, this is a way to control the patients as well. The other topic covered in the guideline was about the transition from childhood to adulthood. This is a major problem. The children live longer with the current available therapies. So till the age of probably From 11 to 18, they are under the care of the pediatricians, but from 18 to 25, we need a transition, and some of the universities or university hospitals are doing a joint outpatient clinic with the pediatricians and the adult nephrologists working together. I heard that in South Africa, and our colleagues in Africa actually ask us to learn about pediatric population and the adult population, because they are the only one taking care of kidney patients in their areas, so they want to learn about these people as well. And a couple of more slides and I'll be done. And there's, of course, the timing of initiation of dialysis. When your GFR, glomerular filtration rate, becomes lower than 20 mL per minute, it's time to get ready for dialysis or kidney replacement therapy. The best therapy that is to be replacing the kidney function is kidney transplantation, cadaveric or living donation. If you have a living donor candidate, you could have preemptive transplantation, which means that you don't go into dialysis, you get transplanted immediately as soon as you need that transplantation. If that's not available, then you decide among the dialysis options: peritoneal dialysis, hemodialysis in-center, or home hemodialysis, depending on the resources that you have in your region. And of course, for the pediatric population, the time to start dialysis might be a little bit earlier because they have restrictions with the growth, and our pediatrician colleagues take into account the growth of the children, and they want it to be a smooth growth so they become healthier grown-ups in the future as well. And lastly, probably, we're also talking about end-of-life care or sportive care. Till recently, probably 5 years, we were just saying that we could offer dialysis to everyone or transplantation to everyone. Now we're not saying that. We're believing that some of the people might benefit from conservative care than being on dialysis, especially the elderly, frail ones, or with resource-restricted areas. This doesn't mean that we don't give any medication or any health care. This means that giving health care at their home, in their comfort, according to their wish. And with the end-of-life care, these are the discussions that my younger colleagues, or you wouldn't think about discussing with your patients, but there will be a time that you will need to discuss with the patients when to stop the dialysis, when to send your patients to home to rest at their home places with their loved ones, and to plan that. That also requires a collective team. And here I stop. And thank you for listening, and I will take any questions. Thank you very much.
Thank you, dear Rector.